Thanks so much to everyone for joining for today's discussion on critical barriers to malaria elimination. How do local communities get back on track? Hosted by RTI International. My name is Jui Shah, and I'm delighted to be moderating today's session. I'm Chief of Party for Inform Asia at RTI International, which is USAID's health research program focused on support for malaria surveillance and elimination efforts in Thailand and Laos with the generous support of the US President's Malaria Initiative. To introduce RTI International, it's both a global research institute and a leading international development organization. We combine these powerful capabilities with those of our partners to co-create smart shared solutions for a more prosperous, equitable, and resilient world. To frame today's discussion, I want to just say a couple of words about the latest World Malaria Report, which was released by the World Health Organization last month. The report highlights progress the global community has made towards controlling and eliminating malaria, while also acknowledging the existing and new gaps and challenges we're all facing. As the report noted, there were 247 million malaria cases globally in 2021, with the mortality rate hovering around 14.8 people per 100,000 population at risk in the same year. Since 2016, cases have been stagnating, and disruptions like the COVID-19 pandemic have further complicated what we know about malaria, how it's spreading, and how we might be able to address that stagnation. I think we're one slide off. Can we go back one slide? Thank you. There has been a lot of progress, however, and we've collectively avoided billions of cases and millions of deaths in the last 2 decades, thanks to a variety of tenacious programs in which we've increased our disease surveillance capabilities, improved prevention and control strategies, and ensured that more patients are accessing effective treatments quickly. With these efforts, more countries are becoming malaria-free, and we can give a special shout out today to Belize and to Cape Verde. Congratulations. We can move on to the next slide. We do have a number of threats to future progress. We're falling short of most of our programmatic targets with a margin of around 50% for morbidity and mortality. We're seeing how wily both the vector and the parasite is. We're seeing more focus and needs around urban malaria transmission, humanitarian emergencies and natural disasters, and a gap in financing, despite this being the largest global fund pot to date. All of this brings us to today's discussion, and luckily we have a fabulous panel of malaria experts from different regions, different roles, and different sectors who can help us address these big challenges and how we might move forward together. So please join me in warmly welcoming Professor Alioune Camara, Manager of Guinea's National Malaria Control Program, Kouassi Eugene Aba, the Regional Technical Advisor for PMI Measure Malaria in Côte d'Ivoire, Dr. Sandra Incardona, Technical Unit Head for MCD Global Health, Dr. Prayuth Sudathip, Deputy Director for Thailand's Division of Vector-Borne Diseases, and Sarvesh Tiwari, Senior Program Manager for Dimagi. You can view their detailed bios at the link in the chat. So to get started on the technical content for today, we'll reflect on the World Malaria Report and that statement that progress against malaria has been a bit uneven and to a certain degree stalling. So we all know that COVID is one contributor, but I'm going to invite each of the panelists to share 1 or 2 other causes that stand out to them for why progress has been uneven and stalling. So let's go ahead and get started. Professor Alioune, can I call on you first, please?
Hello, everybody. I hope everybody can hear me well. I wanted to thank RTI to have welcomed us to this meeting to be able to share some of our experiences. On my end, the reason why we did not reach our goals, and mainly due to the COVID-19, the emergence of COVID-19 caused the program target was not achieved in most of the cases. This goal can be not only based on to the care needed by patients, and as soon as COVID-19 flared up, a big part of the disease, as far as Guinea governmental leaders put in place enough guidelines to contain patients, and taking care of these patients in the healthcare was a bit iffy. So as a result, patients, when they were weakened, were very scared to go to health centers. As you know, malaria and COVID shared the same symptom, which was fever. And so this decision led, as far as Guinea, at times, social trouble, and whereby populations rebelled against measures that were put into place and implemented by authorities on the administrative level. For instance, as far as Conakry goes, which is the capital of the Republic of Guinea, constraints were that as of a certain time, the access to the city was shut down. So all commercial activities were relatively blocked. So at a certain time, the population rebelled, which has actually caused another issue. They were a center of care that were put at the entrance of the health center, and this slowed down the access to the health centers, and this had a big impact. Of course, you still have the input, which was limited on the international level, and in Guinea, we also had election period, and these times are rather iffy and cause social trouble. And this also really contributed to limit this access to health centers and care. And there was also a limit on the level of local resources, which are all coming from the exterior. So since the country is already limited on that level, the country is unable to adapt quickly, and we were having to wait for the foreign partners, to be able to adapt to the situation. Other factors contributing to the slowdown is population migration, among others, also natural disasters and wars and resistance also, which starts to go up in certain regions. A lot of activity, anti-malaria activity, and this also contributed to that factor. One last item, in my opinion, when you look at the publication that was launched, a New England journal that showed that ever since 2000, the progress made for the fight against malaria, we thought it was a way back linearly, and however, this is not always the case. You need many more resources to be able to fight, and sometimes those resources are not immediately available. And so the prevalence for the resources needed go down, and besides that factor, we have other needs on the level of the continent, and you have also epidemics coming in Guinea between 2016 and 2022. 3 outbreaks came back, such as Ebola, the Lassa fever, and the yellow fever, Margou. And it's a lot of outbreaks that come to pile up to without even counting COVID-19. And these are the factors that contributed to the lowering of malaria on the global level was not reached. Thank you so much.
Thank you, Professor Alioune. Can I ask Dr. Prayuth to follow up with experience from Thailand?
Yes. Actually in Thailand, in a couple of years, we a little bit off track of malaria eliminations. Actually, this is there is highly movement of populations along in the Greater Mekong subregions, and also after COVID pandemics and lockdowns, Thailand transition COVID policy to be reportable disease similar to malaria, and that causing high movement of the migrants along the international border, and also increase of the case along the border too. And also in addition to highly movement of populations, and also the political conflict in neighboring country, resulting in illegal movement from other country, from high endemic area to Thailand, and then resulted in unexpected of malaria case along the border. And also this is the difficult part to manage, because we are not planning for these situations. And also we have challenged with using budget and forecasting of services, and also supplies for these illegal migrants that coming with infections of malaria, because our budget is based on annual basis, so it's not flexible to use this. So I think in the future, to solve this problem, we will need to have the contingency plan or a flexible approach to use budget to accommodate with unexpected movement of illegal migrants from other country, and resulted in increase of malaria in Thailand. This is the very challenging for the Thai malaria control program currently. Yeah, that's all.
Yeah, a major challenge. Thank you, Dr. Prayuth. Let's move over to Cote d'Ivoire. Kwasi, can we hear from you? Thoughts on why progress is stalling in malaria?
Thank you very much. Hello, everybody, and thank you to have invited me and to have asked for the Ivory Coast opinion on this panel. And that which I need to say is there's a few factors which are at the base of inequalities in the fight against malaria in the world. I think so. I think that the engagement of the population in the measures of prevention, we know that the malaria is a public health issue, and if there is no real engagement of the community to be able to apply and implement preventive measures, all the strategies developed really can have a negative impact on the progress that we will achieve on the local, national, and global level. You need to also add equity in the access of health measures and health items and tools. Don't forget that there is a lot of inequality in the world, and a lot of communities are very challenged. And in this type of communities which are disadvantaged or underprivileged, if there is no access to health care, this will affect the progress of the interventions that we are enabling. And you need to also add the allocation of resources and its availability. If a resource availability is not there for each country, this will have a negative impact on the progress achieved for the fight of malaria across the world. And also there is a few factors, among others, the global warming, which has a negative impact on equality in the progress which have been registered in the fight against malaria. This is what I wish to add following my predecessors. Thank you so much.
Thanks so much, Kwasi. Excellent points. Can we hear from Dr. Sandra next?
Thank you. I think the other panelists have already listed a large number of reasons of why malaria control is really not so effective anymore. I think what I maybe can add, the first panelist has mentioned, for example, anti-malarial resistance, but we also have insecticide resistance, and that is undermining a lot the effectiveness of vector control interventions like distribution of bed nets and indoor residual spraying in households. Another aspect that I also wanted to mention is that I think that there is still insufficient change in behavior among the communities, despite lots of efforts in behavior change communication. So, for example, many pregnant women do not attend antenatal care, or they only attend it very late in pregnancy, so they miss opportunities to access preventive treatment and distribution of bed nets. The care in public health facilities is also often sought only when the disease has already become severe, or patients seek care in private health facilities where the quality of services is often low. So there is still a lot of do in behavior change communication, I think, and mobilizing communities in really understanding the reasons for malaria infections and accessing services. Also around improving the quality of services and patients being managed in a respectful manner. So that's all factors that really would help a lot in the population accessing services more and benefiting from them and reducing the transmission. Another aspect is also that malaria interventions are often not well adapted to local situations. It's not a one size fits all. Something that works in one place does not necessarily work in another place. So there is really a need to understand better the local situation, epidemiology, cultural behaviors. There are lots of local specificities which can really affect the efficacy of malaria control interventions. And I think there's also a lot of progress to be done in that area. Maybe to also highlight what the other panelists said about conflict situations or unrest, or situations where the population doesn't access the services simply because of infrastructure, and also not well organized distribution of bed nets, indoor residual spraying. Social unrest and conflict situations do really affect a lot. So one example is in Myanmar, where in conflict situation in early 2021 has probably contributed to the fact that malaria cases that have increased in that sub-region of Southeast Asia, half of them were actually coming from Myanmar in that period of time. I'm sure that other panelists have more things to add.
There's definitely no shortage of challenges to list here. So I'll give a couple moments to Sarvesh to see if he has anything to add to that list.
Sure, thanks, Julie. I think most of the challenges that stood out to me in the report have already been covered, and I think Dr. Sandra also just spoke about the drug resistance and how that has been affecting treatment response in patients, context-specific adaptation of these programs. I think two things I'll just add which I've seen in my experience have constantly been a challenge is one, there are still a lot of inefficiencies when we look at planning and running campaign, and when we think of different kinds of campaign, it involves a lot of effort at the ground level to be able to run that. And I think that is something which we still can make a lot of progress in improving. And then accurate diagnosis, unfortunately, continues to be a challenge. And I think these two things, whereas reading the report, constantly kept coming up as some of those challenges. And I think other panelists have elaborated very deeply. So I think I'll keep it brief, but yeah, some of these things stood out for me.
Thanks, Sarvesh. And I think your first point also links with what Dr. Prayuth was saying about the challenges with the funding and just the operations side of things. Well, there's certainly no shortage of challenges, but we're really here to focus on how we pull ourselves out of this slump and how we kind of start to address and tackle these challenges in a meaningful way so that we can get back on track towards our global targets. So we're going to draw on the diverse expertise of the panelists, and I'll ask a couple of questions targeting some of the successes that each of them is acutely aware of. So let's start with Dr. Prayuth. We know that Thailand is getting tantalizingly close to malaria elimination. So I'd like to hear from you what you see as the last mile challenges for Thailand. So at this point, what does the country need to do differently or add to the mix in order to reach that elimination goal that's so close?
Yes, thank you. And we have been thinking of these solutions actually. So what I can answer and use our experience in Thailand currently, we have two options actually. Firstly, we will continue rely on the successful of interventions that we use to reduce cases in 4 or 5 years ago, including the 137 surveillance strategy and also integrated drug efficacy surveillance. Under 137 surveillance strategies, every malaria cases will report within 1 day, and they will investigate it and classify and identify source of infections by 3 days. And for the response, they will respond within 7 days actually. And also we will continue implementing drug efficacy, integrated drug efficacy surveillance, which is to monitor whether the patients complete radical treatments and also complete full-time follow-ups to make sure that patients get radical cure. And this is the main strategy that we used in the last 5 years, together with high coverage of vector control in malaria endemic area that resulted in reductions of the case and also in the active foci in Thailand actually. But to eliminate malaria at the last mile will be difficult. We will need to use the more aggressive interventions to eliminate malaria. And currently we are piloting some new tools to be informative for the malaria program to faster eliminate malaria. And we currently study on feasibility of tafenoquine using quantitative GCPD to kill vivax, radical kill vivax, which is the very challenging in Thailand because currently nearly 99% of malaria cases in Thailand are vivax now. And also we are working with RTI to set up and optimize proactive case detections at the community levels to be able to make our active surveillance effectively. And also we are trying to have the new interventions and collaboration with neighboring country to manage foci across border, because as I mentioned earlier, most malaria cases are from other countries. So we will need to work to manage foci across border near foci in Thailand, actually. So the concept of the whole foci along the border is very critical for us. This is to work with partners and other international agencies to make it comprehensively. But I think to convince high levels of the authority in Ministry of Public Health is very challenging for us, because some interventions are very aggressive. So if we delay on the new tools, so we will concentrate on our existing surveillance system that we implement a few years ago and very successful, such as the 137 surveillance strategy and integrated drug efficacy surveillance. That what we plan to accelerate malaria eliminations in Thailand. Thank you.
Thanks, Dr. Prayuth. Yes, and I think it's so impressive that Thailand has gotten so far relying on this very strong surveillance system, and drug efficacy surveillance has been highlighted, and there's new guidance out from WHO just in the last few months on TES and eventually IDES, and how that's going to be, I think, an area of growing concern and growing focus for our colleagues in Africa as well. Let's move on to Professor Alioune. So we've also seen very steady progress in Guinea in reducing malaria burden, and there hasn't been this resurgence of cases in Guinea. So I think the audience will be really interested to hear from you, Professor Alioune. What's the secret? How is this success happening and being sustained in Guinea? Let us know what the success factors are.
Thank you for the question. I believe that the Guinea made a lot of progress. In order to understand, we started from a lot of cases in 44% in 2012. We went down to 17% in 2021. This is obviously an enormous progress, and the number of deaths has been enormously reduced. Is this a secret formula? But I don't know if it's magical, but I would like to mention the various elements which contributed to this success. The first point is at the start, we had a change of leadership at the national level at the head of the programs of fight against paludism, against malaria. In 2012, we had two people that I'm going to mention because they deserve the merit, Dr. Moussa Keta and Dr. Timothée Gilaboudi, who came to direct this program. With these people, there was a convergence of the resources internally and from foreign donors. At the same time, at the country level, we had the financing of PMI, the World Fund, the World Bank also came sometimes, and the African Development Bank came and brought its help. All this financing allowed us to get these results. Thanks to this, the first task that was done, and it's one of the secrets, is we studied by putting together normative documents to fight malaria. That was the basis. Determine what our vision is, our objectives, through strategic planning. And each sector had its sector planning. So we have we had all the necessary tools and the financing in order to implement this. Once this was done, and we convinced the partners that we needed to implement the strategies to fight malaria. As an example, distributing Migdan. Guinea has between 12 and 14 million people. Since 2016, we distributed about 22 million bed nets to the population in Guinea. That's enormous, and that's in the countryside. In the cities, we had 2 million bed nets that were distributed to pregnant women and children less than a year old. To this day, we have TDRs to screen malaria, and in the hospitals, we do the same. In all this training, we were able to start with the patient care. What did allow this is the various partners in Guinea. We put together what we call a cash register, a common cash register. There was no distinction between regions. Whenever the need arose, we were intervening. Of course, there were some problems, obviously, between the availability of this at the central level and at the country level. We still have gaps, but we have the entrance at the country level. Next to this, we strengthen communications through several channels. Radio, TV, of course, but we also use the community. So the country decided to have community-level healthcare. Today, in every village, you have at least one health worker who is identified and who has been somewhat trained in order to screen a simple case of malaria and to report the data. In parallel, Guinea financed through the national program, it financed the feedback of data. And we used this data, as you know, surveillance is one of the main pillars of the fight against malaria. Today, all data at the healthcare level, at the community level, everything went back up to the center, and all this data was analyzed, interpreted, and communicated with health training. Besides this, you have research. Thanks to the help of CDC, we were able to do operational studies, which allowed us to make decisions at the operations level. Just as an example, in Conakry, which is a capital, it's an urban area. We have a prevalence that was very low, 1 to 2%, whereas at the national level, we were at 17%. The partners wanted to say that we did not distribute enough in these regions. Thanks to CDC, we did some operational research to show that there was still local transmission at the capital level. So it would have been a mistake not distributing drugs in the countryside, a big mistake. So the other part that was also rich is thanks to the partners and everyone, we are not afraid of innovating. Innovation was done in Guinea. For example, doing what we call school leaders and religious leaders were engaged. We engaged everyone at a higher level to fight malaria and in order to disseminate the message with people. The other thing that we were successful in is that during the prophylaxis campaign, we associated the vaccination with the fight against malaria. Now, for 2 years, in Guinea, as we do CPS, since we are in communication with the people. We are in contact with pregnant women and the children. Those who are not vaccinated, we vaccinate them. Pregnant women who did not go to their prenatal visit, we're trying to bring them back to the healthcare centers in order to offer them the whole package to fight malaria. The other success in these innovations is the digitalization. Our whole system was digitalized. Guinea is the first country in the world who was able to experiment with campaign digitalizations at the whole country level, and we succeeded. And I believe this is one of the main successes. There still is work to do. The resources are limited, and we need to find even more acute strategies to maintain our success and to be able to eradicate. Among other things, we need to have strategies that are more stratified. We cannot use the same strategies everywhere. We should select our strategies according to the profile of each region and implement them in order to be efficient, in order to have a bigger impact. Another point is there's resources at the local level. And we need to mobilize these resources in order to compensate the various gaps that are going to happen in outside financing. Is with these two tips, we will have the possibility to cover the last mile in Guinea. Right now, everybody does what they can, and we will continue fighting to eradicate this disease. Thank you. That was for Guinea.
Thank you, Alioune, for that comprehensive overview. I'm hoping the audience is getting a taste that while we had so many challenges named at the start of today's session, there's also so many wonderful success factors we can point to. And I love how Alioune's comments went all the way from kind of the leadership level and highlighting certain champions to talking about how informative data has been to tailor strategies and to maybe consider some interventions that might not have been put into place. So kudos to you and the whole team in Guinea for the tremendous success. And we wish you the best onwards towards elimination. Let's move on to Côte d'Ivoire, which is a highly endemic country for malaria. One of the main strategies has been rolling out ICCM, which requires tremendous coordination across a number of MOH departments and programs. So I'm hoping that Kwasi can help us understand a little bit what have been some of the challenges and successes with that coordination across these departments and how that has kind of tied into the policy framework that's helped the ICCM roll out across the country. Over to you, Kwasi.
Thanks everyone. Yes, effectively, Côte d'Ivoire adopted the ICCM strategy, which is an integration of the cases. This strategy targeting the training, the support to healthcare, community healthcare workers, the services and the drugs to help treat, but also the referencing for children under 5 years who are 5 for the healthcare centers. Their patient care is not always easy. So there were several challenges in the coordination and the collaboration between the various departments and programs. Now, for the challenges in the deployment of ICCM, we need to mention the engagement of the MOH and the national program of fight against malaria, as well as the community level. The engagement of the community level and the implementation of everything that's normative, strategic plan, for example, this was very helpful for all the players to meet around the same table in order to better exchange, in order to orient the priorities. When it comes to ICCM, so what we need to notice is the implementation of a framework, of a permanent framework for consultation at the community level. These consultations include, like I was saying, the national program to fight malaria, the community level fight, the healthcare training, and all the partners in the development. And so the synergy of interventions contributed to the development of a package of activities and the development of the curriculum, training curriculum, very well adapted to the community healthcare workers, mainly since these healthcare workers don't have a very high IQ. So the definition of these packages and this training for these healthcare workers and their status was also discussed in this permanent consultation framework in order to better address the various interventions. So by strengthening their capabilities in a customized level, allow the synergy of interventions with all the partners. Today, a lot of partners, as CQDN, the PMI, allow a good coverage of Côte d'Ivoire, and they deployed ISC, the healthcare workers, to fight malaria. We also need to add the engagement of the private sector. Today in Côte d'Ivoire, a lot of private companies work also in the fight against malaria. So the engagement of this private sector, of course, the coverage is not complete for all the people in the private sector. But the big corporations who are engaged in the fight against malaria also do their part to reduce malaria burden in Côte d'Ivoire. A lot of things were done. The distributions of insurance. A lot of these strategies allowed us to make available the entrance to the healthcare workers. It's true in the ICCM strategy, the malaria interventions distinguish themselves from other interventions like pneumonia or diarrhea. But a lot of efforts were made in order to make available the entrance, like rapid diagnostic tests at the community level, the treatment with CTA at the community level, and the ease of using these strategies by the healthcare community care workers. We use a big intervention at the technical and financing level from our partners, which allowed us to better use the deployment of ICCS. However, the coverage is not complete. Some areas do not benefit from these interventions, and so we need to think to increase the number of community healthcare workers. And in the mobilization of resources, we still have work to do in order to get more healthcare workers at the community level in order to implement the ICCM strategy, and also the entrance linked to diarrhea. We need to mobilize our resources in order to make these entrants available. Another challenge is the equity in access to interventions at the community level. Some areas are not very well served and are difficult to access. Therefore, the strategy cannot reach this type of populations. It's very difficult to better implement the ICCM strategy. Something else also. It's the interventions of all partners. We need a lot of coordination meetings. We need to standardize the various viewpoints. This has to happen at the district level as well in order to implement the various activities to execute the strategy. This is what I wanted to mention about the implementation of ICCM to fight malaria. Thank you.
Sounds like a fabulous example of bringing together so many different actors in a way that's building a community and engaging people in malaria and across other diseases as well. So thank you for sharing that experience with us. Let's move now from the country level to the global level. Sandra, MCD Global Health is supporting ministries of health and national malaria programs in many places with their national malaria strategies. So as you reflect on some of the things that came out from the World Malaria Report, what are some of the things that you think are most important for countries and stakeholders to emphasize or to focus on in order for us to continue to make progress against malaria?
Thank you for that question. There are indeed many avenues to improve and accelerate the fight against malaria. And it is definitely a disease that needs to be attacked from many angles at the same time. And of course, that requires lots of efforts with good coordination and quite some funding, of course. From our work in so many countries supporting ministries of health and national malaria control programs, I would see three main critical items that are really very important. One is the human resources, and that ranges from program managers down to the frontline health workers. All of these need to have good technical capacity, but they also need to be motivated. They need to be recognized for their work, and there needs to be a strong accountability throughout all of these levels. So one of MCD's approaches that contributes to that is the outreach, training, and supportive supervision, known as the OTSS. That helps really identifying gaps during on-site visits, address some of them immediately through on-the-job training, and of course with proper follow-up and repeated visits to tackle other more structural challenges. For malaria diagnostics specifically, that was mentioned as one of the gaps as well. These OTSS visits actually provide an opportunity to assess the competency of lab technicians and identify those that would need to be prioritized for refresher trainings. That's just an example. And the particular need for really strong human resources is at the community level. It can really be a big game changer if the community health workers have strong capacity and strong motivation for preventing and managing malaria in the communities, along with the other diseases, of course, as well. A second element is the quality of data that has also been mentioned in the discussion before. If you have good quality data, you can better adjust interventions and investments. There has been already a lot of capacity strengthening done in this area, but it's often more at the local and regional levels. But low levels health workers also need to really be part of that effort, and they need to be given easy tools to enter and use data. Quickly, a third element that is also very critical is the innovation. And that does not necessarily mean only new technology or new tools. It can be simply more innovative and effective ways of using already available tools, like more effective programmatic coverage, better adherence of populations to these measures, and also our capability to better adjust the interventions based on changing epidemiologies or climate.
Yeah, thanks, Dr. Sandra. Those are excellent points. And I can see how all three of those are linked, because with better data, you can produce better innovation, and that all feeds into the HR as well. So thanks for highlighting those points, which I think everyone can relate to, regardless of what context you work in. Let's move on to Sarvesh. Can you highlight some of Dimagi's experience in developing, piloting, and rolling out ICT tools and platforms that strengthen surveillance? We've heard a number of the panelists reference surveillance and the importance of data in the work that they do. And so we're looking forward to hearing from you what Dimagi's role is in this.
Thanks, Julie. What we have done is we have developed and deployed multiple ICT tools across Southeast Asia and in the Sub-Saharan Africa, and primarily partnering with organizations like GSI, RTI, different organizations that we have in the consortium. And these tools have focused on ICCM campaigns such as IRS, Mass Drug Administration, as well as some of these have been around clinical trials as well. So few examples that come to mind are we did this project with the USAID PMI, which was focused on combating malaria with indoor residual spraying campaign. This is something which was scaled to 17 sub-Saharan African countries. So a lot of learnings were shared between these countries. It used, and some of the functionalities that it had, it was using like a two-way SMS functionality. The users, the beneficiaries could also talk to the system, whereas the system could send conditional alerts. There was case management, there were some advanced reporting to drive overall IRS planning. Another project that we did was the national scale project in Mozambique called Upscale, where we worked with the Malaria Consortium, UNICEF, and the Ministry of Health to create the app. And this application has been helping the Ministry of Health in delivering integrated community case management, so ICCM in really remote communities, and also kind of providing decision and diagnostic support. So for this, we built few tools to drive data quality, such as respiratory rate counter, or again, like this also has SMS-based functionality or multimedia-based counseling. And this, as I said, like this has scaled nationally, so it has kind of been able to provide that value at the national level for the government there. We also deployed a tool for Mass Drug Administration campaign in partnership with the CDC Foundation in Haiti, an e-diagnostic application, again, to drive accurate diagnosis in partnership with FIND. So there are a few of these. And then in Burkina Faso, we deployed GETA as a diagnostic tool again, which was rolled out to 86% of the health centers in Burkina Faso, and it captures individual level data for all children who are under the age of 5 and who are accessing these health services. So there are a bunch of different tools, and these are just focused on malaria related, and they're for surveillance at large. We have also been able to support different ministries, different governments, different organizations in COVID-19 related surveillance, or during Ebola outbreak, we had deployed a lot of these tools. So, and these applications, when we work, we generally work in an ecosystem. So we know that there are certain value these tools bring in, where we have integrated with the National Health Information System. So this kind of helps in reducing the duplication of effort. There could be a facility or a community-based tool which is providing value there, but we also this also helps in making sure that the reporting is taken care of. And the tools have been able to help drive quality of service delivery, bring efficiencies in campaign planning and implementation, and strengthen that district and community level health system. So these are a few examples. I'll pause there and probably see if there are any further questions, or I can elaborate on anything. Thank you.
Thanks, Sarvesh. And I think that easily fits into the other comments we had about the challenges with equity and the need to engage communities and have data really in the hands of the community members that are kind of the last mile sites. It is time for us to wrap up. So I just wanted to say thank you to all of our esteemed panelists. Thank you to the audience for coming out here. I think when we've got a topic that's this exciting and we have a group group that's as committed as everybody who's on the phone today. We always run out of time. So I'm not surprised that we're behind. I want to encourage everyone who has a question we didn't get to or that didn't get a chance to be asked to get in touch with the organizing committee here at RTI International. We'd be happy to put you in touch with any of the panelists to get your questions answered. And I'm looking forward to seeing our collective progress throughout 2023. Thank you to everyone for joining us today, and bye-bye.